So welcome to the C3AI Digital Transformation Institute Colloquium. Our mission is to attract the world's leading scientists to join in a coordinated and innovative effort to advance the digital transformation of business, government, and society. As you can see, we are a consortium of many strong universities and companies with support from C3AI. This is the sort of the end and also the beginning of our colloquium, our summer 2021 colloquia, and we'll be kicking off in June. So please keep track of our activities on our webpage. You can catch our former talks on our YouTube channel, and this one as well will be posted to the YouTube channel shortly after it is done. The format is a 40-minute presentation with 15 minutes of Q&A. You can ask questions in the Q&A feature, which will go directly to the speakers. Those questions will be answered generally at the end of the talk, but you can put your questions into the Q&A at any time. If you see a question you like, you can upvote it, and so it'll get answered earlier. We will answer as many of these as we can. Today's talk is about an AI-assisted COVID-19 medical guidance system using the C3AI suite. We have a number of presenters. The PI is Louis Shaw, there are co-PIs, and there are students. And many of them are going to be present here today to give you more information about this project. Louis Shaw is one of my colleagues in the Department of Computer Science at the University of Illinois. He graduated with his PhD from Carnegie Mellon in 1985, and he joined the Illinois faculty as a full professor in 1998. He is the Donald Gillies Chair Professor of Computer Science and the Daniel C. Drucker Eminent Faculty in the College of Engineering. He's a fellow of IEEE and ACM. He has served on the National Academy of Sciences Committee on Certifiably Dependable Software Systems and the NASA Advisory Council. His work on real-time and safety-critical system integration has contributed to many technology programs, including GPS, Space Station, and the Mars Pathfinder. In recent years, his team has been developing medical GPS systems to dramatically reduce preventable medical errors that claim 250,000 lives per year, the third leading cause of death. And with that, I will turn this over to Louis. Louis, you can share a screen and turn on your video and unmute.
Okay. Well, can you see me?
Yes, we can see you and we can see your screen.
Oh, okay. So this is a team presentation about a collaboration between University of Chicago Medical Center, OSF Children's Hospital of Illinois, and UIUC on AI-assisted COVID-19 medical guidance system using C3.ai suite. I will give a quick overview on medical best practice guidance system. Professor Rosu will give a quick overview on software safety assurance. Zikun will talk about AI-based early warning. Sean and then Xiaoyu will talk about integration with C3AI and gave demo. Dr. Jeni will talk about her perspective from a physician's perspective on COVID-19, cardiopulmonary resuscitation. And Dr. Jeziorczak, I always pronounce his name, so I usually call him Dr. Paul. He will talk about his perspective on lung fails, COVID-19 lung fails, from a clinical perspective. The AI-enhanced medical best practice system is to provide clinical guidance in the real time during critical care. We have been developing prototypes using computational pathophysiology. I'll explain what that is. For ARDS, that is lung fail. And for pediatric, cardiopulmonary resuscitation. And we have been using executable formal model K to code the medical algorithm for verifiability. You will hear from Professor Rosu. And we will conduct simulation-based clinical evaluation at University of Chicago and at OSF. So to provide care, to improve care, we integrate with C3.ai to recognize the early signs of clinical deterioration in order to initiate early intervention. Prevention is always better than treatment. So the key feature about our guidance architecture use what we have pioneered, technology known as computational pathophysiology to track and manage complex disease dynamics. Computational pathophysiology maps organ impairment stages defined in medicine into organ state machine state. Each organ state has its diagnostic criteria and medical best practice treatment guidelines. The state transition of those concurrent organ state machine and their interactions transforms pathophysiology described in natural language to executable software. So if you look at a diagram, basically we have three components: the clinical interface and the disease models. So we have the renal model, respiratory model, and the cardio state model. So they work concurrently and interact with each other, which captures how the patient's condition evolving and then provide appropriate recommendations. And we integrate with AI, and we look 6 hours ahead to say and give reliable early warning. So this is a quick look about what is a sort of organ state machine look like. So this is, we are integration the trend analysis using AI with the respiratory state model. It is a simplified one, so used for illustrator ideas. So on the upper left corner, we have this respiratory SOFA score. SOFA is an abbreviation for sequential organ fail assessment. So 0 means no fail, things are just fine, and 4 is the worst. As we can see, the station transition will occur. Basically, the key parameter is the blood oxygen level, the PaO2, divided by the partial oxygen level when you're breathing in. So the blood oxygen level and the oxygen level in the oxygen air mix ratio essentially tells us how good is the lung functioning. So that's why this ratio is a key parameter in this simplified diagram, which tell us which state the patient's in. As we can see that if we reach the moderate lung fail state or severe lung fail state, they both have near 60% of mortality rate, which is extraordinarily dangerous. because more than half the patient will die on average. You said why both of them are 59%. So what is the difference? Why the physician separate them into two states? Well, it turns out that if you are in severe state, even you are being, say, rescued, you will have a lot of complications, or you are likely to have long-term or even permanent lung damage, which is much more severe, even you make it to alive. And also your the time stay in the hospital is much longer. So even the mortality rate is the same, the clinical outcome about life, so the quality of life likely is different. So that's why physicians separate them into two. Okay, so Professor Russo.
Okay, thank you, Professor Shah. As Professor Shah showed us, as part of computational pathophysiology, we have these state machines that describe various functions, but eventually all these need to be implemented as programs, as code. And as we know, code can have errors. In this project, we decided to take no chances, basically, with coding errors. There are many other concerns that we need to have when we can have when we design the models, the finite state machines. The last thing we want the doctors is to worry about errors in the programs themselves. For that, we decided to use the K framework, which is a state of the art in designing. It's a meta language, a framework to design languages and tools for them to verify correctness of code in those languages. The picture to the right gives a high-level overview of the K framework. The yellow in the middle shows the programming language, the target programming language, which so far K has been used in connection with many programming languages, C, C++, Java, JavaScript, and so on. And then what the K framework does, once you have a formal model of the programming language, or a formal semantics, how we call it, then the K framework gives you tools for that language, starting with implementations, executable models of the language, and ending with very complex formal verification tools for that language. And what is extremely important for this project is that all these tools, including implementations that are generated, are correct by construction. That means that there is no need to verify these tools are already correct by the way they are constructed. So we decided to employ the K framework for this project so that in the end, there is no possibility for errors as we go from the finite state machines describing the medical procedures to the actual code implementing those. It is always interesting when you take a state-of-the-art system and try to apply it to a complex application different from everything that that system saw before. And you realize that you need to extend it in some very interesting ways, which is what happened also in this project. As we try to use the K framework, we realized that there are certain aspects of it that were never thought for doctors and for this application domain, such as inter-process communication and how to interact with different applications on different tablets, on different desktops. So we had to basically add an interface, a textual interface for K to make it really easy to connect with other tools. And also, we had to add the timing, support for timing to start timers and to measure time within K, otherwise pure computational paradigm. So those were very interesting and they were done. And once we had those, we could design this programming language, what we call a domain-specific language, programming language for doctors, for defining, for implementing these medical guidelines. And we call it MEDIC-K, MEDIC with a K. You can think of MEDIC as a programming language for writing medical guidelines in the most intuitive and beautiful possible ways for that domain. And at the same time, using the full power of K that has been evaluated and assessed with a lot of other languages before. If you have any questions about K, please feel free to ask them in the Q&A box, and I will answer them both as the talk proceeds and at the end. Now I'm going to tell you a few words about MEDIC. Next slide, please. So we can think of MEDIC as a version of K which is friendly for physicians. It provides all the capabilities of K, but in a syntax that is easy to understand by non-programmers. What you see to the right is a snippet of the MEDIC code implementing the finite state machine that, that Professor Louis Shah described. As you can see, there are names, there are states, there are variables, transitions, how you initialize the state machine, and so on. So all that, there is a one-to-one mapping between that and the beautiful graphical diagrams that doctors understand and write and define. So once you write such a definition, then MEDIC can automatically generate an implementation. So you don't have to implement these finite state machines in Java or C or C#, where there is plenty of room to make mistakes. Humans make mistakes, programmers make mistakes. No matter how good they are, they make mistakes from the right code. So what we wanted here is to eliminate this risk completely. So we generate the code completely automatically from this MEDIC definition. So you only have to think of the definition. Is this the right model that I want to execute? And if yes, push the button and the whole code will be generated automatically, correct by construction. So this is done. What we'd like to do, we are not done yet. We started working on flowcharts, basically generating nice graphical pictures from these models that are more intuitive, which will be needed eventually as we translate all this research into a product. But for now, for us and for our collaborators, the textual interface is good enough for now. And then later on, we also want to analyze, to generate formal analysis tools as well from these MEDIC models, and analyze properties, to analyze these medical guidelines. Because what if they have inconsistencies? What if you can follow a procedure and another procedure, and there is one particular corner case in which a patient is given two conflicting drugs, for example, right? So this can be very hard to figure out, but a system like K will allow us to do such analysis, validate models. Next slide, please. So if you have questions about MEDIC, please feel free to ask them also in the Q&A box. I will answer them as we proceed. But to give you a very quick high-level overview where we are with MEDIC so far, we designed the syntax and implemented it. So we have a parser and the syntax as you saw it on the previous slide. We have a complete example end-to-end, a CPR machine that is written completely in MEDIC and also other prototypes, but this one is complete end-to-end. The textual interface also works. It interacts with the GUI without any performance penalty. That was a bit of a challenge for us, but it works. And also we have the core part of the MEDIC semantics. So MEDIC is a programming language. All programming languages evolve in time. Java, there was Java 4, Java 5, 6, 7, now with Java 10, right? So languages evolve, same with MEDIC, will evolve. So far we have a core semantics and we expect it to evolve as needed and as we work with physicians and understand better the domain and what is needed. So that will be an open-ended feature, but we already have some features that we know we want to add as soon as possible to the language. And also the other way around, we like to take a MEDIC definition and generate a pretty printed variant of it, a flowchart with colors, boxes, arrows, which are easy to read by physicians and assessed by physicians. And as I mentioned, we also want to do formal analysis, particularly reachability. We call it reachability analysis. Basically, when we analyze the models that certain bad states cannot be reached. A bad state could be that the patient dies. Well, I exaggerate, but there could be many other bad states that you don't want the model to allow. And those will be taken to physicians and reevaluated. And we hope that eventually physicians will be able to write these models themselves. And with that, I will stop here and we can move on. Please ask questions in the Q&A box.
For the early warning, we built a machine learning model that aimed to predict patients' condition 6 hours in advance. More specifically, in the case of ARDS, it will be predicting the SOFA score for the respiratory system of a patient. So this model helps the guidance system to provide additional possible interventions and suggestions of close monitoring when a patient has a high possibility of deterioration in the next few hours. The data that we used to train and test the model are extracted from MIMIC3, which is a relational database available online that contains medical data of patients who visited the ICU of the Beth Israel Dickinson Medical Center in the time span of more than 10 years. All vitals and demographic features that were entered in the guidance system are included in the model. They were organized and aggregated into 1 hour non-overlapping timestamp to handle the issue of different sampling frequency of the available data. So data were aggregated and imputed based on feature sampling frequency. More specifically, we took the mean value for the features with sampling frequency less than 1 hour to make sure the size of the time span across patients are consistent. Then we perform a sample and hold interpolation for specific vitals with sampling frequency greater than 1 hour. For features that were not measured throughout the patient states, we filled in with normal value based on the medical knowledge and other patients' variables, such as age and gender, that were available. Here is a short summary of the statistic we got by running our model in using the MIMIC3 data. Since we have 5 levels of SOFA score for the respiratory systems, where 0 indicates normal and 4 indicates severe ARDS, we include a table that shows the precision, sensitivity, and F1 score for each level. So from the ROC curves and the table, we can see that our model performed relatively well in most cases, and we are expecting to make further improvements based on our current model.
Our project aims to develop AI-assisted medical guidance system utilizing the power of C3 AI Suite. This diagram shows the blueprint of the integrated system. The clinical data from the training dataset and real application will be converted to C3 data types, stored in C3 data storage, and used in C3 machine learning pipelines for accelerated development and model training process. The prediction results are first converted to analytic types and UI element types to fully utilize the convenience of using C3 Suite. This is our eventual goal if we can reach some data privacy agreements with hospitals, which have some proper de-identifying process. As for the current milestone, we have developed a COVID-19 ARDS guidance system prototype, which achieves 2 main goals. First, model ARDS treatment guidelines published by authoritative medical associations using computational pathophysiology. The current prototype is based on NIH-NHLBI ARDS Clinical Network Treatment Protocol, in short, ARDS-NET protocol, and Johns Hopkins University and Hospital COVID-19 treatment guidelines. In real practice, working with collaborating hospitals, this treatment model can be customized for clinical simulation and research. Oxygen therapy to raise the oxygen level in patient blood is a main treatment for ARDS. Mechanical ventilation is the most common medical intervention for ARDS oxygen therapy. In mechanical ventilation, physicians need to collaboratively adjust the tidal volume, which is the volume of inhaled air for each breath, respiratory rate, which is also the breathing rate, fraction of inspired oxygen, and positive end expiratory pressure, which is a pressure applied by the ventilator at the end of each breath to keep alveoli from collapsing. This recruits the closed alveoli in sick lung and improves oxygenation. By adjusting these 4 main settings, physicians need to reach 3 interdependent goals. Each of these can be influenced by several of the setting variables. In the meanwhile of increasing ventilation efficacy, physicians should also minimize ventilator-associated lung injuries. Mechanical ventilation is a complex treatment process, and our guidance system is designed to assist physicians to better adhere to the guidelines. The second goal is incorporating patient status prediction models powered by C3 AI Suite. The system sends de-identified clinical measurements to C3 AI machine learning model endpoint. The prediction result facilitates physicians to conduct timely medical intervention and optimize clinical resource management. Here is a demo video with an example clinical scenario. At the beginning of a clinical session, the system prompts the user to enter the patient's age and weight. The formula commonly used for estimating predicted body weight, given height and gender, can be found by clicking the info button. Let's assume a 60-year-old patient who weighs 70 kilos. Next, the system prompts the user to input the patient's vital signs and lab values. This measurement input box will show up periodically based on the monitoring guidelines in the suggested treatment protocol. Let's assume the patient has the following measurement values: 125/70 for blood pressure, 120 BPM for heart rate, 30 BPM for respiratory rate, 77% of blood oxygen saturation collected by pulse oximeters, 38.5 Celsius for temperature. And assume the arterial blood gas analysis result is not available for now. This tab color codes the measurements within normal range as green and outside normal range as red. Next, the system provides a list of high-risk conditions. Let's assume the patient has diabetes. According to the input so far, the system estimates the patient is at high risk for poor outcomes. The estimation is based on the Johns Hopkins publications, which can be found by clicking the info button. On the left panel of the system, we can find the clinical measurements and the treatment settings arranged according to different organ systems. This prototype supports manual input for these values for simulation and training purposes. In actual clinical scenarios, the system will be integrated with the hospital EMR system to obtain real-time patient status. Let's assume now the arterial blood gas analysis result becomes available. These can be entered to the system by the respiratory AVG tab. Let's put 7.39 as blood pH, 35 as partial pressure of carbon dioxide, 57 for partial pressure of oxygen. The system processes this value and notifies the user of suspected mild ARDS. This assessment is based on Carrico index. The details of ARDS severity assessment can be found in the info tab. The system models ARDSnet protocol and suggests the recommended initial mechanical ventilation settings based on the current patient status. In the mechanical ventilation tab, let's put 40% as the fraction of inhaled oxygen and 500 milliliter for tidal volume. The system pops up an alert indicating 6 milliliter per kilogram for tidal volume is recommended according to the treatment protocol. Let's change this to 420, as the patient's body weight is 70 kilograms. Let's put 30 for ventilation and respiratory rate, as it is the baseline minutes ventilation rate. Let's assume the patient's blood pH drops at this point of time to 7.25. The system then notifies suspected acidosis. To meet the pH goal indicated in ARDS-NET protocol, it is recommended to increase the respiratory rate. Let's set it to 35. In the top right part of the system, the do's and don'ts for COVID-19 ARDS treatment are listed as reminders. In here, we can find high positive end expiratory pressure, in short, PEEP, should be used for patients with moderate or severe ARDS. Since the current patient is in mild ARDS, we should not set a too high PEEP value. However, if the input value of PEEP is too low, for example 3, the system will generate an alert. In the Info tab, the system provides the table of positive end expiratory pressure and fraction of inhaled oxygen combinations for reaching the oxygenation goal in ARDS-NET protocol. We can see, as FiO2 is 0.4, PEEP falls in the range from 5 to 8. Let's put 8 as a PEEP setting. Let's now assume the first measurement of patient's plateau pressure is available, and the value is 35. To reach the plateau pressure goal, we should consider decreasing the tidal volume gradually in 1 milliliter per kilogram steps, and the plateau pressure should be monitored at least once in 4 hours. If we decrease tidal volume too fast, for example, directly to 250, the system will generate an alert. So let's change this to 350, which is the original value 420 minus 70. In the background, all the measured values are de-identified and aggregated periodically, then sent to C3AI prediction model to estimate the patient status in the future. Here, we receive the prediction result that the patient may develop moderate ARDS after 6 hours, and the possibility is 67%. The prediction result indicates deterioration, so the system notifies the user to consider medical intervention in advance. The frequency of sending prediction requests and the rules for aggregate time series data are determined by patient state at the time and can be customized by physicians. The next step of this project will be collaborating with hospitals to model the suggested early intervention based on the prediction, use machine learning methods to recommend patient-specific precision treatment, and integrate into the C3AI suite and the guidance system.
Okay, so next I'll give an overview about the pediatric cardiopulmonary resuscitation guidance system. It's a different system that's in the development. And then the most prominent feature is we're going to convert it to a web-based system, so it can be easily launched inside a browser. And it will be especially helpful because we have less setup time during the COVID period. And then it will also display the real-time patient vital signs and the future predictions on a big screen. So as you can see on the diagram, we'll extend the screens to a big screen using the Wi-Fi protocols. And the design of the system will also streamline the process in saving patients' life. And another feature of the system is we're going to add a feedback system so the supervisor physicians can give suggestions to those physicians who are taking the medical practice, the protocol practice. Next, I'll give the overview about the screenshot of the new system. On the top right corner, we can see a big screen. So we'll have the vital signs and the waveforms show on the middle of the screen. And then on the left side, we'll show the countdowns of the clock for each of the steps. And on the right side, we'll be able to show all the histories. On the lower left corner, it's the main session. So the physicians will be able to keep track of all their operation histories. And then on the bottom right, it will be the training session. So supervisor physicians can give mock inputs to train the physicians. Next, we can give the stage to Dr. Paul.
Hi, I'm Priti Jeni. I'm a pediatric critical care physician at the University of Chicago Comer Children's Hospital, and I'm looking forward to sharing the clinical perspective. Before we begin, it's important to know our true north. So this is our target: increasing survival from pediatric cardiac arrest and improving post-arrest patient outcomes. There are elements that have been proven to be effective in improving resuscitation outcomes. These include high quality CPR, adherence to the American Heart Association PALS guidelines, pediatric advanced life support, team performance, hemodynamic directed CPR, and following these guidelines. Next slide, please. Hi. Despite an abundance of evidence for achieving these targets across population, our team still struggle to achieve the needed metrics such as high quality CPR. These metrics are extremely and subpar performance related to position and cognitive load associated with these events. So in our current state, we have subpar performance. While we have interventions pre and post arrest to improve resuscitation team performance, such as simulation-based training and post-arrest debriefing, we do not have any comprehensive intervention to apply intra-arrest real time. There is research demonstrating electronic decision support and cognitive resuscitation performance. Next slide, please. Slide, please. In partnership with the University of Illinois at Urbana-Champaign, Professor Shah's lab, and the C3AI, we are very fortunate to collaborate in the development of a pediatric cardiopulmonary resuscitation guidance performance system to help teams meet the targets towards achieving a high quality resuscitation event. We use our simulation lab to develop and test prototypes of the system with our resuscitation teams. Next slide, please. In phase 1 of our study, we held numerous interviews with ICU nurses, pharmacists, and physicians to identify the best layout and content of the tablet, as well as the large data display. In phase 2, we'll be using this prototype during iterative simulations to evaluate for usability and identify the best model for use. The final prototype will be undergoing testing in the sim lab with assessment of CPR quality, team performance, and adherence to PALS guidelines, as well as the new COVID-19 PALS guidelines. Next slide, please. Here you can see the schematic of our randomized crossover design, where teams will be tested on their resuscitation team performance, both with and without a guidance performance system. Next slide, please. The ultimate goal is to link prediction with performance. to target interventions intra-arrest that will increase the odds of survival and improved patient outcomes. To do this, we aim first to develop a system that effectively human behavior toward improving CPR quality and adherence to designated targets. And secondly, allows for the integration of machine learning to help the team to identify the interventions and or modifications needed to optimize in real time resuscitation quality and outcomes. Thank you.
So to echo some of the things that my colleague stated in her slides, the goal for lung injury and lung failure long-term is if we know the car is going to crash, can we prevent that? And if it is going to crash, can we lessen the amount of injury? Fundamentally using these tools and AI-based learning to predict illness progression, to be able to get to that a little bit earlier can fundamentally change not only the hospital course of the patient and that outcome, but their long-term morbidity and how they can come back to function after they're out of the hospital. Leveraging these software and adjuncts, we can also expand globally expertise in areas that may be lacking of appropriate medical care and fill in those gaps to take care of those patients. Next slide, please. To move beyond similarly, we will take this into a simulated based environment where we can look retrospectively at case studies and actual patient data that we know the longitudinal outcome and see using the C3 AI platform, how far into the future could we have predicted clinical failure or a change in the pathway that that patient was following, looking to see if there were times when we could have intervened sooner and longitudinally progressed while that patient was in the hospital and even afterwards, so that we can prevent that illness progression. Next slide. So our goal from here is to expand with our institutional review boards. As many of you know, patient data is sacred. It's protected by HIPAA. The goal is to get de-identified data from those patients so that we can expand the ability of the software to run through a number of different patients. And once we simulate the system through that, we can do real-time simulations in a low-stress environment to validate the product real-time, and then from there move into a live clinical setting to in the intensive care unit to see how that works.
I am taking it that this is the end of your presentation, and maybe this is a time to open for Q&A. So let's see if the audience would like to submit some questions. All of the speakers should turn on your video and unmute.
But before others ask questions, can I ask a question?
Yes, please.
Since medicine is not my domain, I'm curious, how do you design these state machines, right? That simulate organs or procedures, and how many iterations it takes until you get to a point where you have confidence in one of these machines? I know how to implement them, how to make them correct in code, but I don't know how you come up with them in the first place. That's fascinating.
I would say that sort of like you're doing a PhD all over again. So in some sense, is that medicine is moving very fast. And then with the help like Dr. Jenny and Dr. Paul, we read the appropriate literature, and then we start translate those basically the text. Sometimes we're getting lucky, like the ACLS, they're already in the flowchart form, but that's an exception. So most of them are in texts with lots of tables, as you have seen. So, so we do the best we can, and then we build the system, and then the physician reviews it. And then we, let's say, through many iterations, so we know it is clinically correct. And then we will talk to you, Professor Russo, and say, okay, now replace the code with something we can formally verify. So that, because when we review by physicians, we can only go through so many cases. But will there be always correct consistently? That's why I guess one day I walked into office, I said, I can use some help. And I'm happy that you are joining our team.
So the audience can put questions into the Q&A, but since there aren't any there yet, I'm going to ask a question as well. This is one of the most interdisciplinary projects that I've encountered so far. And I wonder if some of you would like to comment on how, do you find that the context in which this is all about using AI to advance discovery, does that bring the two sides together, the medical side and the computer science side? Or do you perceive AI differently, and do you perceive the use of AI differently?
So when we encounter, as you can see, what we actually do of using AI is not exactly what we proposed. I guess we need to do what's right, then stick with the original plan. So one problem with AI is that normally if you want to mimic a physician's behavior, enormous amount of data. So we have meetings with C3.ai, with hospital, and found to get that massive amount of data, say, for example, to tune the ventilator, and we just don't have the data. So now we said, what is the next best, which can really help the physician, but do not need such a massive amount of data, and also that it turns out is prediction. So to look several hours ahead. Then, for example, we talked to Dr. Paul. We said, hey, in 6 hours, with at least 75% of probability, good enough so that you can do something. Let's hear from Dr. Paul again.
Great. How about the perspective from the clinical side? Would you like to talk about how you experience this kind of interdisciplinary working environment and the role of AI?
So honestly, for me, it's been great working with Louis and his team. And, as he's saying, that the crystal ball of medicine is if you can predict that someone's going to get sick and intervene earlier to try to either prevent how sick they're going to get, is a little bit of the holy grail of medicine. And there are lots of fabulous clinicians that can do that on the fly. But the world is big. There aren't many of these people. And so for me, working with, the software and the AI environment is really opening the door to the possibilities of how we can interact with, technology and clinical practice. From the early days of having the Palm Pilot, where you can look up what the appropriate antibiotic dose would be, to something really more fundamental to how can I prevent lung injury, or even if it is going to happen, how can we lessen it so that long-term, as our goal is as clinicians, the patient should leave the hospital and go back to a relatively normal life. How can we help that be a little bit better and maybe not so severe from our treatments, so that we didn't burn the house down while we were trying to heat it at the same time. And really, it's been fascinating to have just access to Dr. Shaw and his team. Take what we're seeing clinically and translate that into something that has real meaningful across the board implications.
Great. So Dr. Jeni, what's your perspective?
Yes, I would echo the same sentiments. I think the merging of medicine and engineering is really a beautiful thing. I can say the collaboration has, I think, challenged us in a good way to sort of think outside of the box and create and work towards creating something that would not be possible without each specific discipline. And it provides the opportunity to answer really critical problems in medicine that require engineering and AI to solve, and have been challenges that as Dr. Paul has been saying, it's sort of this: if you can predict it and identify the appropriate intervention, you have the potential to prevent the problem before it gets bad. And so that is really exciting work to be able to be a part of this and make an impact in that way. So been really
super. Okay, now I'm just going to ask if any of you have any conjectures about the future of AI. Or a comment about what do you think the real limitation is in making these advances? Is it the quality of the data? Or is it the techniques? Do the techniques in AI need to become stronger? So do you have any thoughts about where the attention needs to go? This can be answered by any of you.
Okay, let me give it a try. What we have learned is the current generation of AI is a purely data-driven. And the medicine world and engineering world, especially for safety critical systems, such as medicine or aviation, is model-driven. So the key challenge is to make sure we can integrate the pure data-driven AI with the medical models. So the integration of the model with AI is really important because normally, let's say we look at the normal AI, say recognize somebody's picture. The input format is the same, right? You just take different pictures. But in medicine, it's completely different. First, you don't sit there waiting for data. You need to suggest to conduct additional tests. As the patient getting more serious, for example, then we change X-ray to MRI. As you can see, the input vector changes from state to state. So bringing the computational pathophysiology, then you will really avoid the traditional, one potential pitfall for the traditional AI approach, which is the big challenge called out of distribution problem. In fact, in each stage of the disease, you have different drug, different modeling, and you have different sorts of symptom or clinical measurements distribution. Essentially, in each stage, we have different distribution. Say stage 1 cancer, well, you can take it out easily. Stage 4, don't forget, surgery is not an option. So the idea of medicine and AI can work beautifully together. So integrating AI and scientific model is really the way to go. And historically, we have something called Kalman filtering. It integrates data-driven filtering from radar return and the model about the aircraft. And we know, as people said, the rest is history. And it was a Kalman filter by integrating from the model-driven approach or signal processing-driven approach with models, with aerodynamic models, being recognized as a historical accomplishment in engineering. So hopefully we can achieve something Kalman has achieved many decades ago in medicine.
Well, that's great, Louis. That's very inspirational. Okay, so with this, I just want to thank you all. It's great to see what's happening at this connection between different universities and different fields. And I'm very pleased that you are part of the C3AI DTI. Thank you all very much. And we'll see you next time. Bye.
Thank you.
Thank you.
Thank you very much.